My dear esteemed audience who have joined us in such a large number today, it's my great pleasure and honor to present to you one of the very dynamic, very prominent, and very promising young endocrinologist who has achieved at a very young age the greatest miles in academics, patient care research, and he is none else than Professor Dr. Suhas Erande. Dear friend, Professor Suhas, in his workplace in Pune, in the Akshaya Center of Diabetology and Endocrinology, has excelled in many fields. To make a long story short, I must mention about his large number of publications and let me congratulate him for having achieved 12, more than a dozen of international publications in a very short time. One of the passions of Dr. Schwartz had been his, his passion for the patient education, and he has published books on the patient education. One more of his book on the fatty liver, what I call the most important issue in the current times, is seeing this publication in the coming Diwali time. He has a large number of patient base. He is a regular speaker in RSSDI, in the API, and in all the forums, ESI, all the forums that matter, and has contributed immensely for the teaching and learning program. But what distinguishes Suhas is his astute clinicianship, his thirst for knowledge. I have done many programs with him, and I always amazed at the depth of the knowledge, the communication skills, and his friendly and very friendly nature, which is unique. My dear Shwas, today is a very auspicious day for the Indian diabetic audience and for the Indian diabetological science. I request you, Suhas, in your inimitable style, to present to us your ideas regarding challenges of diabetes in India. Please give your presentation to enlighten us, to give us the knowledge, and knowledge is power, about the challenges of diabetes in our country. Over to you, Suhas. All is yours.
Hello, this is Dr. Suhas Herande. I'm going to talk to you about a few challenges which we face when we diagnose or manage type 2 diabetes in India. So let's have our slides, please. Yeah. So that's my topic or the issue today. And we have a lot of things. When we say challenges for diabetes care in India, we always are harping on a broader scene of healthcare problems in our country, which is a huge country, 140 crores of population, and quite a significant, you can say, geographical, cultural variation. Access to diabetes care or medical care itself can be a challenge. And there are other issues, especially health beliefs, illiteracy, less health literacy, etc. So we have the challenges for diabetes care in India, which include improved education to alert the population about the risk factors for diabetes. This is extremely important. Unless the person knows that what is diabetes and what are the threats or dangers of diabetes, how will he come to the doctor? Then training of the patients to manage their disease more effectively. Let me tell you that my guru, the patron founder of the RSSDI, Professor MMS Ahuja, always insisted that diabetes education should come first when we treat diabetes. So training the patients to manage diabetes. Development of more structured care delivery. So the demand of diabetes is diagnosed, assessed, and then the delivery of care happens accordingly and over a period of time. And then the management of cardiometabolic risk factors. We are not only dealing with sugar when we say diabetes, but we are also dealing with high blood pressure, high blood cholesterol, problems with the nerves, problem with the blood vessels, cardiac issues, renal issues, retinal issues, psychological issues, sexual dysfunction, depression, association with lot of cancers, non-alcoholic steatohepatitis, liver problems, etc. So it's essential to diagnose the disease early and start aggressive management of sugar and associated cardiovascular risk factors, which I mentioned just now. It is also mandatory to individualize the glycemic targets. Every diabetic patient is not to be treated similarly or same. depending on age, depending on his motivation, depending on the set of complications which he has or has not, we have to design the treatment accordingly. Then there are a lot of barriers, mind you, there are a lot of barriers, and identifying these barriers to diabetes management is extremely important to improve the quality of diabetes care, including the improvement of the metabolic control and the diabetes self-management. And what could be the barriers? The patient himself could be a barrier. So he will have some strong health beliefs, myths or misunderstandings, etc., and lack of, let's say, awareness about health or diabetes. So lack of awareness, economic stress, denying the risk, and you can say a lot of patients just deny. They say that the problem of sugar is only on the laboratory report. They don't have any complaint. This is not the real fact. The raised sugar is always going to damage a lot of organs in the body. Then the stress, the patient says, no, 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 I'm completely happy, I'm completely stress free. But the doctor can see that he is under stress. And the patients are reluctant to change their behavior, change the activity pattern, change the diets, and they feel that they are actually, all these are quite a big challenge. That's what their feeling is. And then there are barriers, like for example, I already mentioned difficult access to medical facility or diabetes care. So rural barriers such as high rates of illiteracy, poverty, different socioeconomic strata and the challenges thereby, multilingual population. So if we are to design a diabetes education program, we have to prepare it in multiple languages so that multiple people understand it very easily. There are issues related to culture, religion, the customs related to the person, superstitions, beliefs, and these pose a lot of problems for a medical professional. Now, what are the strategies to manage pre-diabetes? You know very well that pre-diabetes is something which is these days the latest EASD. Hardly a week ago in Stockholm I was, and the term now which is being considered for pre-diabetes is early diabetes. Okay, early diabetes, no pre-diabetes. The first step in managing patients with pre-diabetes, which is generally a fasting sugar between 100 to 125, post meal or post glucose challenge sugar between 141 to 199, or an HbA1c between 5.7 to 6.4 is what is pre-diabetes. So the first step is managing patients with pre-diabetes is encourage strict lifestyle modification, because not allowing that pre-diabetes to become a clinical diabetes, it is nothing but diabetes prevention program which was conducted in US, some other countries, even in India. So lifestyle is the most important. And what is lifestyle? Let the person do more than 180 minutes of physical activity per week, and a caloric intake anywhere between 1200 to 1800 kilocalories per day. If the patient is overweight or obese, he has to reduce weight. At least the weight loss should be at least 7%. In addition to lifestyle management, obesity, anti-obesity agents like, for example, orlistat, lorcaserin, or phentermine, topiramate should be considered for obese patients with prediabetes. These days, we certainly have more classes of drugs like SGLT2 inhibitors, or maybe the GLP-1 receptor analogs, which also can be thought of in reducing the excess weight of the patient. Healthcare providers can also consider pharmacological agents like metformin, pioglitazone, voglibose, liraglutide, or some others to treat such kind of situations. And if the medical management fails to achieve glycemic control, advanced measures such as bariatric surgery, especially if the patient's body mass index is grossly high, let's say more than 30, especially more than 35, then certainly bariatric surgery also can be thought of as the treatment of pre-diabetes. And then there are a lot of therapeutic strategies which we can think of. Novel medication therapies, as I have just now mentioned, the SGLT2 inhibitors like Cana, DAPA, or empagliflozin, GLP-1 receptor agonists like liraglutide, dulaglutide, semaglutide. Now semaglutide oral also is available, or DPP-4 inhibitors like Sita, Saxa, Lina, or alogliptin, teneligliptin in India. Early initiation of combination therapies rather than going from one step at a time, that is metformin to start with monotherapy, then to add a sulfonylurea or any other agent, then a third agent. So that inherently brings in what is called as a clinical inertia. So rather than that, depending on the patient's entry HbA1c level, we can think of starting the patient on metformin plus vildagliptin, for example, or metformin plus pioglitazone, metformin plus SGLT2. So dual therapy right from the start. And we have a lot of classes of drugs like alpha glucosidase inhibitors, pioglitazone, gliptins, gliflozin, GLP-1 RH, metformin itself, which are not going to give you hypoglycemia. The SGLT2 inhibitors have cardiorenal, excellent cardiorenal profile, beneficial profile. The GLP-1 receptor agonists give you an excellent weight reduction and cardiorenal protection. So these options can be thought of. What are the other actions? We talked about illiteracy, less health awareness. So patient education and empowerment, very important. Both of these are key steps in assuring the good glycemic control and maintaining the good glycemic control. The facility and adequate manpower for both patient education and empowerment may not be available even in the major cities of India. Priority must be given to creating awareness among the public and to patient education. Let me share with you that I have written half a dozen books for patient education in diabetes, patient education on diabetes and its complication, lifestyle diseases, and what are the uh, remedies to really tackle these. I have published all these books, and I am happy to share with you that absolutely you can say thousands of people have really purchased and read these books. Patient education programs are generally cheap and cost effective. I can swear by that, especially after the post-pandemic, post-COVID pandemic. Telemedicine has certainly come to the fore to help lot of situations in medicine. So telemedicine can be a strategy for closer monitoring and intervention to achieve not only better metabolic control, but also to help global care of individuals with concomitant chronic diseases. Patient may not come to my clinic or hospital. Patient may be at his home, but by telemedicine, we can always have a chat with the patient. Patient can share his complaint. He can show some problems, especially in our field, diabetic foot ulcer, swelling of the feet, appearance of the face. Lot of things can be seen by me on a, you can say, video call, and then I can certainly modify my treatment accordingly, and the patient can upload his laboratory reports also on the telemedicine apps, and I can view them prior to talking to the patient. Over the last decade, several studies have addressed the feasibility and efficacy of telemedicine strategies in management of diabetes, and many studies have proved telemedicine is certainly something which is feasible. And post pandemic, even the medico legal permission has been given for video consultation in our country. So these are some, you can say, some of the salient features which I wanted to share with you. Thank you so much for your patient listening.
Dear
Yes, sir.
friends, today in your presentation, you touched upon two things: the healthcare providers' education and the patient education. What is your take, Suhas, today for changing a dent, making a dent in the diabetes care in the country? How important is the healthcare providers' education? And what's your comments on that?
Yeah. Sir, in my presentation, I insisted on my own teacher, Professor M.M.S. Ahuja's inculcation that diabetes is basically a disease where education is important. Education pertains to the patient first, the patient's family. Sometimes, if there are type 1s, then it is the teachers, the peers, and the most important, the diabetologist or the endocrinologist himself has to keep on updating himself, and he has to spread the knowledge amongst his colleagues who could be probably the family physicians, the primary care physicians, or the allied specialists. And diabetes remains a multi speciality job when we deal with complications. So education remains the pillar of diabetes care wherever we are. That was the insistence of Professor Ahuja.
I think you remembered my teacher, Professor M.S. Ahuja, also. And I
Sir,
must tell you, in his own words, he used to say that diabetes is a relentless disease, relentless in its onslaught on the heart, kidney, eyes, liver, etc., etc. But the advances in diabetes also are relentless. And one of the functions that Suhas you have carried out in your life is to bring these advances to the doorsteps of the healthcare providers. Am I correct? So that
yes,
is
sir.
what healthcare providers education, to update them, to give them the latest knowledge about diabetes is a great job, and that has to be done. and this updation has to be constant. And this is one of such program we are doing today, which is objectifying that only, that we must update our audience about the latest education. The second thing that you said I liked most, which is the paramount importance, that diabetes today is not a single disease. If you know about diabetes, you know the entire medicine. It affects from the hair till the nail, from head to the toe. Therefore, it becomes imperative on the part of our clinicians, our practicing doctors, to know about the diabetes and its various system it affects. It becomes a great call to us, because for a practicing busy physician to keep abreast with the diabetes affecting the heart, kidney, mind, body, the various aspects, the skin, the everything it affects. So it becomes a great call, and the healthcare provider education goes a long way for that. What do you think that about the patient education? And that has been one of your passions to us. So how will you
Yes.
put the importance of the patient education and how we should take it forward?
Considering that diabetes is a chronic disease, and considering that in the it is inherent in the management of diabetes that the patient needs to be tutored, taught, and confirmed about lifestyle modification, which pertains to broadly two things. Number one is, of course, the dietary discipline, and number two is the physical activity, physical exercise, so that the patient doesn't become overweight or obese. So these only two, let's say, issues in patient education are very important. Patient can get lot of difficulties there, depending on his literacy index, depending on the family support, depending on his own motivation, or the set of complications which the patient has. So we have to handhold the patient through all these circumstances. The financial challenges which the patient may face, we have to carry the patient along with us. And if it is possible, then the patient typically or ideally should be able to think like a diabetologist or a physician. So if his sugars are all right, he should not be less bothered about his blood pressure or cholesterol or kidney problem or the retina, etc. So diabetes control is at least ABC control, if not some other organs, that we have to teach. We teach the patients, and the centrality of lifestyle modification, even for a newly diagnosed diabetic or for a long-standing diabetes with maybe set of complications, that we need to really insist, and we have to accept the challenges, the patient's preparedness to listen to us, yes or no, patient's health awareness, yes or no, patient's financial status, age, etc. So we have to go beyond that, and we have to try to reach as many of our diabetic patients, in fact 100% of patients, as possible.
Beautiful. I think what you said is reflects what Jocelyn had said. A patient which is who is educated, who is aware, and who knows maximum, gains maximum, and also lives longest. It has been also studies by Indian colleagues, Mohan and others, who have shown those who live for 100 years, they are those Indian persons with diabetes who know everything about diabetes, not only knowing, you rightly said, implementing it. Implementing it. Suhas, you did discuss in the course of your talk today about the physical activity and the diet. Why do you think the physical activity in Indians are so low? In the ICMR in-depth study, Suhas, which I chair, I must tell you the physical activity was abysmally low, and even leisure time physical activity. What will be your message to the people who have joined the doctors and few public, and how the doctors can educate their patients about the physical activity?
Sir, so looking at the public or general population, we have been trying to fight actually for last around 15 years by what is called as a addressing the adolescents, the students in the schools who are between 9 years to 14 years. So fifth standard to ninth standard, we spare the 10th standard exam going students,
Yeah,
and we try to inculcate the importance of exercise both in the student or the index, the family, the parents, and the teachers, so that these days the screen time is reduced. These
yeah,
mobiles and the televisions and the computers and whatnot. So, if we are able to do that, then certainly with the whole set of parents, teachers, and the peers, we have seen that the liking or the fondness of physical activity, sports, and exercise certainly is implementable in the early age for the school going children. That has we have surprisingly, but actually common sense wise, we have seen that that reflects on the behavior of their parents also. So the parents also reduce their screen time, and they also start engaging themselves in more and more of physical exercise. This is something which is only pertaining to around 1,000 odd students, but we have stuck to that for last quite a few number of years.
I think it is a very laudable project.
Yes,
Very
yes, sir.
laudable project. As you rightly said, in the school health program of Government of India,
Yes,
we also aim at the students between before the 10th, ninth up to ninth standard. It is also part of their curriculum. I must
yeah,
also tell you that human body has four parts to us. You know it better than me.
yes, sir.
The soul, the mind, the vital, but what is most important, the physical. If you do not have a good physique, the everything falls flat. So this physical education, to my mind, must become absolutely essential, even given more importance than the mental education, vital education, and spiritual education. Sharira madhyam krodharma sadhanam. So the,
Yes, sir.
the, the physical education must become very important. And also it has been rightly said that the physical activity in type 2 diabetics in our country, or even type 1 diabetes, has benefits which are great, like diminishing insulin resistance, controlling better control of blood glucose, giving a sense of well-being, taking away the diabetes, taking care of the lipids, giving a good sleep, giving a sense of great sense of well-being. I know that, Swas, the day I do not do my activity, physical activity, we don't have that sense of well-being. So your message to the masses is very clear, that definitely do physical activity for about 30 to 45 minutes. We advocate about 45 minutes every day in the week,
Yes, sir.
and you cannot do anything, at least walk, because you cannot ever forget to carry your legs. So, what are the other challenges that the Indian diabetics face? And would you like to list the other challenges that you spoke about today? Once again,
Yes, sir.
for the benefit of the doctors.
Right. Sir, the main challenge I feel is we, even in a city like Pune, we get a significant number of people who hail from the taluka places or the uh, villages, or broadly we'll call it as rural area. So they have to travel a distance to come to us or the city and the medical facilities. That's their challenge. Two, it is likely that they are less literate. However, that illiteracy percentage is certainly going down now. More and more people are getting educated. However, the health literacy is still low. The awareness about the problems which pertain to our country, like maybe cardiovascular diseases, metabolic diseases, obesity, and some amount of cancers or infective diseases, that is certainly low. The awareness of preventive activities, physical exercise, diet, or regularity, checking yourself for the certain parameters, whatever blood pressure or maybe the biochemistry, ECG, etc., without having a complaint, that is something which is still low. So I believe that is an area where we have to certainly improve, and we have to
I,
involve
I
the doctors from the rural areas also. We certainly try to do that. Tomorrow itself, actually, the Indian Medical Association Pune has a program where half a dozen specialists are delivering on the lecture. One of them is me. So we are trying to deliver those kind of lectures tomorrow itself. So we have to rope in the doctors even in the rural areas or remote areas, so that the correct health messages can be percolated, dissipated to a larger amount of population who actually need it, rather than the sophisticated maybe MRIs or angiograms which we do
agree. I
here.
think
Probably
I
the
cannot agree more.
first
You
steps
know,
can be taken there.
this focus on the doctors in the rural practice areas, people who are coming from those areas, and also the tribal areas, the areas which is less privileged, is of paramount importance. I congratulate you. You rightly said that if you do not educate them, and they also said very beautifully, we don't give them the right message. If they get the wrong message, everything will topsy turvy. So it is our a very important job to do it. Now, I've got two quick questions to ask you. One is, what's your opinion about the diabetes specialist nurse educator, which you touched upon? And
Right.
what do you think, how it is going to change scenario? You can be very brief in your answers, Subhash.
Yes, sir. Sir, the person with diabetes has some kind of a fear or phobia about talking to me or a doctor. So he relates his issues better with a diabetes educator. So the communication is more effective as far as the patient's own storytelling or experience with diabetes is telling, especially insulin taking patients, complication patients, they tell their, let's say, difficulties or stories better to the diabetes educators.
I think very well said, because doctors in the Impact India study we found SWAS can give only 2.5 minutes for their patients. But for a
Sir,
chronic disease like diabetes with lifelong complications, the diabetes nurse educator, it is the diabetes educator, it is the specialist diabetes nurse, all in one. They can provide the best education. I cannot agree more. What are the other challenges that you face to us and you like to address them?
yeah, sir, I believe that financial challenges certainly happen to be up. Following that literacy or less health awareness, financial challenges. We have good medicines these days. However, lot of these medicines, which are
I,
cardiorenal protective,
I
a
cannot
significant
agree
number
more.
of them may be
I
beyond the reach of a typical person in India who needs these medicines.
I think
Forget
I
about
cannot
the
agree
intervention,
more.
but theyese
Was
medicines
you
certainly,
have taken the word out of our mind, and now I must tell you that. But having said that, was there is some silver lining. Today, many of the drugs which has gone off patent have become very very
yeah,
affordable, and also there is a constant competition to bid the price, and that is to the benefit of the patients. Number two is a diabetes care. Today we have the permutation combination therapy, and the combination therapies, India is the author of that. And the combination therapy in India, see, I'll give an example. Swas, you have yourself said that many times. A sulfonylurea metformin combination, are you getting my point? Or a gliptin metformin combination has become very very affordable. And the according to government of India, the highest selling combination today is the metformin sulfonylurea, and next to it gliptin and sulfonylurea. And this combination in our country, I call it 4 A's. It has become affordable. Am I correct, Suhas? It has
yes,
become
sir,
appropriate. Appropriate. If you combine gliptin with metformin, you address
yeah,
about 5 out of the 8 ominosuccinate. If you combine gliptin with DPP4 inhibitor, you address 7 out of the 8 ominosuccinate. So they have become very affordable. They are also appropriate. They are available and accessible across the length and breadth of the country. But your issue is very correct. We do not know the amount of problem these people have in the rural areas. They have nots. So I think it also becomes important on the part of the government and charitable organizations where the drugs must be available. In fact, we have met the Ayushman India people, and they are considering this of making the new drugs, which are not costly today, to be affordable at a very, very comfortable price for these people by subsidizing
sir,
it. They have said they
sir,
will
yeah,
subsidize. It's a very important issue. So you
yes, sir.
rightly said about the economical issues. What are the other issues that you think the Indian diabetics face today?
Uh, Barring the literacy issue and barring the affordability issue, I believe the old customs or the health beliefs, superstitions certainly continue to be maybe the bedbug,
Yeah, I
and
think
it is a
very
continued
rightly.
consultation and tutoring which can certainly get rid of that.
I think it's very rightly said. You know that we had people who are totally against the allopathic medicine, and now recently in a legal issue, we have taken over them and we have won that case that they cannot do such type of preaching. Therefore, as you rightly said, the myths, the false beliefs, the rituals which are not scientifically correct, the 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 wrong blind issues, that has to be taken care of, and that has to be dispelled. As you rightly said, Swas, I liked it. Constantly we have to fight against it and give the correct picture before our people. And we have to say that the diabetes, the disease which is today, may not be totally curable, but totally controllable. And diabetes control, even 1% drop. How many times you have said this was in your lectures. You have said it 1,000, 10,000 times, but it needs repetition to tell them that even 1% drop in your H1C can give a great benefit in your life, longer life,
Yes,
complication free life. And I like the way you are told earlier also, that combination therapies in India which we gave to the world is 3 C's. It is comfortable, it is cost effective, and the compliance of the patient is 100%, because the pill burden comes down. So the the combination market in India, like the metformin sulfonylurea, gliptin with metformin, or gliptin with the gliflogens, has come to stay, and they have made the practice of medicine much easier. And also, I don't say totally affordable, but more affordable, because the
Right.
pill burden comes down, the cost comes down. So, what your comment on that combination therapies?
Absolutely. Fully written. In fact, not only for diabetes, but some comorbids like hypertension or cardiac problems, dyslipidemias also. We certainly are using more and more of combinations simply to bring down the pill burden. The administration, if at all, by a healthcare provider, a family caregiver, or an institution person, and less burden on the memory of the patient also, be it a working patient, be it a old patient. So that's very easy. And the cost of medicine certainly comes down rather than two separate of metformin or sulfonylurea. Combo always is cheaper.
Absolutely,
So cost comes down, compatibility, the compliance, everything improves. The timing compliance also improves. So all
absolutely.
in all, the gain is everybody is a winner here.
Yeah, it's a win-win for everybody, Subhas, as you rightly said. And now the West is helping us. The United Kingdom and the United States, they're going for this combination therapy. Coming to the South Asia, I found in the Colombo, in the Sri Lanka, the combination therapies are being taken up more and more. UK, where I was partly trained for a couple of years, there was no combination therapy. Today, they're trying to imitate us for the combination therapy that has come to stay. One or two final questions to us is about why in India we miss our complications. Why don't you screen our complications in time? And what is your take and the message to the public about the healthcare providers and the public about the monitoring of the complications?
Sir, my oft repeated statement, which I have written in my books for patients, diabetes is a silent killer. Unless I look for a heart problem by an ECG or a stress test, unless I have a view or a photograph of the fundus retina, or unless I see the urine albumin or kidney function or the blood vessels or the nerves, I can't say that these complications are not there. So, diabetes remains a silent killer. The complications could be even more silent. That is something which I insist in my book as well as in my patient education sessions. So, I believe that proactive approach is the only one by which we can certainly detect and maybe manage the diabetes complications. Otherwise, every heart problem we see in the ICU only.
Yeah, I think you are absolutely correct. And also, most important to us that you have written in your books, that today, for the early detection of the complication, we have got tools. As you rightly said, microalbuminuria for the kidney problem, the systolic time intervals, blood pressure checking for the heart disease, for the fundus retinopathy, at least a fundoscopy, or at least a angio to see for the leak. I mean, you have got early detection of complication is possible. And also, Shwas, as you wrote in your books, there's a point of return, point of no return. if,
Yes,
if
sir.
you if you if you if you take care early, you can totally revert back the complication to normalcy in India. If you do not take care, it becomes late, then also it becomes visible, but still it
Yes.
is better to look for it. My final question to you: what's your comment about the blood glucose monitoring in our country? You can only change, Suhas, what you measure. You cannot change what you do not measure.
Sir.
So what's your complication about monitoring diabetes today in our country, and how we can give it a fillip to take it forward?
Sir. Uh, a typical American person or person who stays in America, if he gets diagnosed with type 2 diabetes or type 1 diabetes for that matter, then his consultant gives him a glucometer, and the
Yeah,
educator starts teaching him how to use a glucometer, how to maintain the glucose diary, how to send that glucose diary reports maybe through the mail or the intranet or maybe actually in the clinical follow-up. And the clinician or the diabetologist screens and acts on that. So if we really are able to do that, and sir, I can always share with you that we have at least two advanced glucometers these days, which have a set-in kind of a monitoring system. The glucometer talks to the patient's cell phone,
absolutely.
smartphone, and the
Our
smartphone
phone
can
can
be
also
connected to
connected
my
to phone.
hospital system or maybe my cell phone. So the circuit is complete. The patient's monitoring, whether he is doing it or not, can be ascertained, and with the educator, with the nursing staff, or with the assistant doctors involved, the patient's family members also involved, even the glucometer monitoring, SMBG also can be something which can be made effective, because the CGMs are good scientifically. However, the penetration could be a bit of challenge because of cost and all those things. So SMBG, certainly we have to take initiative. We have to teach the patient, or our team teaches the patient, and the patient does it, gives a feedback on that. That's the only way.
Best. I think I cannot agree more. Before I close, I'll just mention three things from your talk that has really impressed me. Number one, you said that diabetes control is paramount importance. I'll just go one step further to say that nowadays we have given a slogan to us that the first year control matters. If you control in the first year, you get maximum legacy effect. And one of the papers published in Journal of Diabetes Care in 2022 March by Littiping has shown that the first year control in about 34,000 patients having 6.5 to 7.5 H1C eradicated complications. If it was very high, 13 years later, they had a lot of complications, even early death. That you have rightly said. Second thing you rightly said, that we have the drugs, the combination therapies, which are affordable, which are cheap, which are appropriate. It must be properly used in our population. And also, these drugs have become very safe because of the lack of hypoglycemia, lack of weight gain, da 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 da. So they have to be done. Third thing you said, that every doctor in our country, every practicing physician in our country has to be updated about diabetes constantly. And we have to also update the persons with diabetes to get the maximum benefit. And you rightly said that one cannot be blind to the socio-economic aspect. I really liked it, Swas, a person like you talking about the socio-economic aspects. And taking up socio-economic aspects for Indian diabetics is a paramount importance. It is a win-win for both. Swas, I thank you profusely on my own behalf, on behalf of the audience who have joined today, for your excellent presentation and answering
Thank you so much,
about
sir.
12
Thank you.
questions.
Seek your blessings, sir. Thank you
Thank
so
you.
much, sir.